Good afternoon, ladies and gentlemen. My name is Hein Dane and I have the pleasure to share this meeting. This meeting is on the impact of heat on children's health. Children are among the vulnerable population in the heat, and they are seriously under-investigated as compared to adults. Therefore, we organized this small symposium with 4 speakers that are experts in the area regarding heat strain in children from pregnancy to childhood. That's also the line of this presentation. We will start at an early age, and the last presentation will be more about childhood. There are about 20 people attending in this room, and we expect about 40 online. So hello, people online. I hope you can all hear and see me. You're more than welcome. The presentations of today will be recorded, and a movie will be made that we intend to post online, that we intend to advocate. That's the great idea. If you have any questions, don't hesitate to ask them. We organized in such a way, Nienke will take note of all the questions that you have online in the chat, so that later in the general discussion, Nienke can rephrase the questions and the experts can give an answer to it. That's the idea. And then here the people in the audience, you have a small preference, so I will treat your questions first, and then I will go to the people that attend online. Without further ado, I would like to invite the first speaker. The first speaker is not physically here, but he's an expert from Karolinska Institute in Sweden. His name is Jeroen de Bond. He's an epidemiologist from the Karolinska Institute. So Jeroen, I invite you, I give you the floor for your first presentation here.
Well, thank you. I hope you can hear me well from the Netherlands. Thank you very much for this very kind invitation to come and present here. It's a pity I could not join. I'm actually also, as you expect, I have a really Dutch name. I'm actually also Dutch, but I live most of my life outside the Netherlands. So it's actually a pleasure to be invited in Amsterdam, even if it's online. So I thought today I'm going to give you an overview of current research that we are doing, or our group is doing at an international levels on the effect of heat, and looking more on perinatal and pregnancy outcomes. I think I might have been a bit very technical in some aspects, but maybe that's also interesting to know a bit more about the methodologies behind. And maybe it's too technical, or you have some questions that raise about different models or methodology, I will be pleased and hopefully I can answer them. So going to start the presentation. So we are here and we know that climate change is a fact. It's here and it's not going away. And we have seen this increase of this extreme climate events in the last decades that have increased substantially. And if you see in all the news heads, it's all about affecting health, about our proper health, affecting mortality through heat waves, through air pollution, droughts, wildfires, the flooding in Spain, for example. So it has a direct effect on our health. And actually, the World Health Organization also says that climate change is now I lost the sentence, but that climate change is the human face. It affects us directly on our health, so it has a direct impact on our daily lives. And I think they also have tried to summarize a nice overview of how climate change per se is not affecting us directly. It goes through different climate-related hazards such as extreme weather events, heat, sea life rise, air pollution, vector distribution, water scarcity, reduced food productions that have a direct on multiple health outcomes such as mortality, respiratory outcomes, waterborne disease, mental health. But however, the effect of how vulnerable we are, it depends on this called vulnerability factors such as socio-demographic, socio-political factors, but also about, they call it the exposure, about how the systems are prepared to this kind of to this specific event. And today, as you as we already have heard, we're gonna focus more on early life, and I work mainly on pregnancy, such as Jasper, but also on child health. And it's not that we just do this because we want, but actually it's very important. And what was already mentioned is about the vulnerability that they are against, that they are more susceptible against this, in this case what we're going to talk about, heat. And actually within the World Health Organization and the UNICEF, there was a call for action actually to protect maternal and newborn and child health from the impact of climate change, because they have mostly been neglected against adaptations measures. So there's a call to have more empirical evidence on the effect of climate-related exposures on maternal, newborn, and child health. And there has been already some kind of evidence across the globe, but but comparing their results has been extremely difficult because everyone uses different methodologies, different exposure models, different data sources. So there's also an urgent need to harmonize larger data sets across the globe to do reproducible science and have more accurate estimates. And one point is where we study that. And most studies have been conducted in high-income countries, but actually those are not the countries that are more vulnerable against these effects. So as we see here, this is a figure where we see that areas where actually poor countries are more vulnerable to the impact of climate change due to many factors. Also, they have higher levels of exposures, but also about what I said before about their health systems, their preparedness against this extreme weather events, the housing constructions, the urban design. All of them make them in a way more vulnerable, despite having contributed less, no, to the greenhouse gas emissions. So it's important to look at high income countries, but also in low and middle income countries. And today I'm going to show you specifically two studies that we have conducted in two different studies. One is in ALERT, where we've looked at the heat association between stillbirth and Africa. And also I will mostly talk about the current work that we're doing in the High Horizon, which is a EU Horizon projects focusing on heat and early life health. And I will look both at the short term, meaning acute effects of heat on multiple birth outcomes, but also looking at longer term during pregnancy, like trimester specific exposure across the globe and in Europe specifically. So I will start with the ALERT study. This study was published last year, and the first thing, like when we think about this method, about this study design as epidemiology, is like what is the evidence, the mechanistic explaining the association between heat exposure and, for example, in this case, stillbirth. And on the one side, you have the direct effects, that there it's not a lot of studies have shown, but some studies indicate that the effect of heat during pregnancy can have some embryogenic and fetal impact and placental changes that during the pregnancy can alter, for example, induce some epigenetic changes, fetal growth restriction, but also some more hormonal immune system changes in just thermoregulation that can increase oxidative stress. So more into depth biological mechanisms that I don't want to go into that, but that have shown to be linked to, for example, preterm labor, hypertensive disorder, small for gestation that unfortunately can lead to antepartum or intrapartum stillbirth. But when you also talk about with specific health professionals in locations such as Africa, where this study is done, that also within the health facilities, you can have some indirect effects that they've told me that when there's an extreme heat event, their facilities are not prepared to this event. They don't have air conditioning. So they work in very extreme heat conditions that their reaction, it might not be as fast as it would be during normal temperatures. So the responsiveness and resilience can lead to lower responsive to an emergency during labor that can unfortunately lead to intrapartum stillbirth. And then there are also some physiological factors, including stress or environment affecting nutrition that can lead to stillbirth. So I just want to say that there are a lot of direct and indirect effects that can lead to a potential stillbirth. So how did we do this study? So this is an alert study that is led by, it was not focused on climate. It was really to promote and reduce stillbirths in Africa. And we have data from 16 hospitals between 2021 and 2023, where they have an harmonized software where they introduce all the data, what is very common in the Netherlands or in Sweden, but not as comprehensive done in Africa, where they have the same system. And so all the recruited data on birth and pregnancies was collected during 3 years in this different 6 hospitals. So we have data from Benin, Uganda, Tanzania, and Malawi, and it's all clinical data. So most of the studies previously in Africa are based on questionnaires. So this was really one of the first to include high quality clinical data. And at the end, we were able to include more than 138,000 singleton birth across the different hospitals. And what we looked at is that as there were no specific measurements of temperature at the hospital. So what we did is we downloaded data from satellite data, which is ECMWF, and there you can actually download freely daily levels or actually hourly levels of temperature at the 9x9 kilometer grid. And then we could take daily mean, maximum, and minimum temperatures that you would assign at the hospital level. Because this study is really looking at the short-term exposure, looking at the week before. So then it's not so relevant to know exactly where they live, but more about the temporal variability in temperature on the daily level. And this kind of satellite data can be really useful because it can really capture how the temperature changes during the day, but also during the week before pregnancy. And then when we looked at the outcome, we looked at all kind of stillbirth that included both antepartum, so birth that babies that died during their pregnancy, but before labor, then intrapartum stillbirth that during labor they died. And then we also combined perinatal deaths, like that is combined stillbirth with neonatal death within the 24 hours. Actually, you would like to have within the first 30 days. But as the woman left the hospital, we didn't know what happened afterwards. So we would only know if they stayed for the 24 hours in hospital. So if something happened during those for 24 hours, and we would look at the 4 different health outcomes. So what we did is called a stratified case crossover design. I don't know if you ever heard about. This is a really common design for looking at acute effects. And what we want to do is to compare this case day, what you can see here on Friday, 21st of June, 2022. We look at what was the temperature that week in that person that died. So you look only at the cases. And then we look at the control days within the same month, within the same day. Like, what was the temperature during this week and this week and this week compared when it actually happened? So it's kind of a design that their own cases serve as their own control. And what is really nice of this design is that you don't need to account for covariates like lifestyle behaviors or socioeconomic status, because you look at the individual changes, and then within 1 week that doesn't change a lot. So you only have to look at, for example, factors that can vary daily on a daily level, like maybe humidity or air pollution. You could look at that. And what we did, for example, is what we first did is to look at the country-specific association, so look at each country, and you usually do that because every country has their own maybe climate zone, their own socio-demographic structure, their own health out, like the prevalence of the health outcome. So it's a way to account for the country-specific differences, and then you would do meta-analyze the estimates from each of the country. And it's with temperature, it's very difficult because it's not a linear association. It's not per 1 centigrade increase. You can look at it as a linear because it's you would show it has a different shape. So you need to look at different percentiles. And this is the hard part within the climate sector, is to look at how do we present the results, and there is no correct way to do it. So we did it in one way, so we can discuss if this is the best way. And what we do is like, what happened when you increase from the 75 percentile, which mean like what happened during a warm weekday before labor compared to a very extreme, which is the 99 percentile. Like going from a warm to extreme heat, what happens in the effect estimates. And here we got the main results. And here on the right, we see that an increase from the 75 to the 99 percentile was associated with a 34% increase in all perinatal deaths. And then we also saw, and this was quite consistent across the different countries. And also we saw kind of an association with stillbirth, which was 29%, but not statistical significant, but all was a kind of an indication that there seemed to be some effect on heat on stillbirths. And actually where we saw also one of the strongest effect was in intrapartum stillbirth. And that is what we also maybe would expect biologically, because that is then we know exactly at what time, when it happened, the case compared to antepartum births. And what I want to say is with these curves, so you can see that heat might usually have a U or a G shape, where you can find effects, not so much effects in the better temperatures, like comfortable temperatures, but you see this increase at when we go warmer and warmer and warmer. And what I want to show in this specific study is that actually the curve, it means an increase in the effect was much steeper in intrapartum stillbirth compared to stillbirth and perinatal deaths. And within a climate perspective, where you expect that heat will go more on the right side, will be increasing, like have higher temperatures. There will be kind of an adaptation, but still it is expected that those risk might be increased if there's no any specific adaptation measure. And then going back to the high horizons, we are now looking at both short and long-term studies at multiple different birth outcomes. And I will show you some very preliminary results. So please don't share, just I wanted to show you because they are very interesting. And here we tried what I say to harmonize more data sets across the globe, including both like high-income countries and low-income countries. And here in this study, we are able to include like registry data from so nationwide data from Sweden, Belgium, actually, Belgium, the region of Rome in Italy, and also all nationwide of Greece. And then we have hospital level data using the same data source as ALERT from Benin, Malawi, Uganda, and Tanzania. And then we also have regional data set from South Africa and different hospital level data from the PAHO, which is a surveillance from the regional from Latin America and from the World Health Organization, where they have hospital level data from 8 different Latin America and the Caribbean areas. And here we were able to include more than 5 million singleton births across 15 countries. And here we didn't look only at stillbirth, but we also looked at preterm birth, and low APGAR score. And here also, again, we use this ERA5 climate, which is the ECMWF. Again, we downloaded their data, but we didn't look only at mean temperature, because there's also a question now currently is which heat measure should we include in our analysis? Is it just mean temperature? Is it minimum or maximum? Or are there other indicators that are now available, which is the wet bulb globe temperature is one of the most common, the UTCI and heat index. I'm not going to go into the details what each indicator, but some indicators might capture more humidity, also other capture more accounts for physiological processes such as thermoregulation. And so actually we thought that UTCI would be the best measure because it accounts for, it's related to temperature, but also we know that one of the mechanisms goes through regulation of the temperature of the body. So we used UTCI as our many indicators, but we also compared the estimates if they are the same or not. And then we also looked at the mean, maximum, and minimum temperature. And we assigned that again at the hospital level in where we have hospital data, but for example, in Sweden or Italy, we have actually the location where they lived. So that's a bit more accurate to know what was that maybe that temperature the week before the specific outcome. Just to finalize, the results I'm showing is very much in line with the current evidence. Now we are showing it more in a consistent way with the same analysis, but here you can see in the largest systematic review, which was published last year in Nature Medicine, they actually showed that there are a lot of studies on preterm birth, low birth weight, and hypertensive disorders, and most of them have shown harmful effects. Some might have had show protective, but you can see that most of the studies have shown this kind of complications of heat, and also you can see how many different complications there are linking heat with different maternal and perinatal outcomes. This also indicated to have more studies on maternal complications rather than only on birth outcomes, and maybe also some other outcomes that is now more of interest, such as mental health in pre and postpartum women. It's also very much of interest for future studies. So to sum up, we have seen that heat affects birth outcomes across the globe with actually stronger effects in LMICs. It seems that this last trimester, the last period of the pregnancy, especially also the last trimester, but also last week seems to be the most vulnerable period. And it further emphasized that pregnant women and newborns must be included in climate action and adaptation programs. So to finalize, I want to thank, I went too fast. I want to thank all of our great team that we have within the High Horizon and Alert and all these people that are analyzing across the globe, which is you cannot imagine what a big achievement is to manage that. So I want to thank you, and also the EU High Horizon funding to make this possible. So yeah, thank you very much for your time, and I'm happy to hear some questions if you have any.
Thank you. I hope you can hear the applause from the audience here.
I could not, but I can hear you now.
Okay. So I'll do it again. Thank you very much for this clear presentation, for the worldwide overview of the effect of heat on birth. We will now move to the Netherlands. The next speaker will talk more about the Netherlands. For the questions, I ask you to for the general discussion so that we can keep the time schedule. I'm very pleased to invite the next speaker. He will focus more on the same issues, but then in the Netherlands. Jasper, the floor is yours.
So while we are waiting, let me introduce myself. So I'm Jasper Been. I'm a pediatrician by background, and I still work in neonatal intensive care. So this is one of my patients. Well, I will start by explaining why I am now here talking about heat. But Jeroen also gave a bit of background of why that might be the case. I also had some background in epidemiology besides my training in medicine. So we start here. This is Rotterdam. I know I'm now in a different place in the Netherlands, but I'm inspired by this guy, and I mean this one. This is Erasmus, Desiderius Erasmus, who was pretty famous in the 1500s. And he gave his name, unknowingly, to our medical center and our university, and even his signature, as you can see. And probably he's most well known for this quote, "Prevention is better than cure." And this is really what drives me in my everyday job, because I showed you this is the average patient I treat in neonatal intensive care with our team. We start from about 24 weeks in the Netherlands, which babies of about 400, 500 grams. They just fit in your hand. And this is, I love my job, but rather I would have that it just isn't necessary, and that every baby has a promising start like this one. And I'm sure I could do other things with my life. So preterm birth really is the issue. About 2/3 of my patients are born very preterm, which is below 32 weeks, because then you get referred to a neonatal intensive care unit. And it's not a Dutch problem, like Jeroen also showed, it's a worldwide problem. So this is a map of the incidence of preterm birth across the globe, and it affects about 14 million babies every year. So there's a lot of scope for prevention here. And it is the most important reason for children across the globe to die before the age of 5. And death is only the tip of the iceberg, because prematurity also leads to a lot of organ problems, a lot of problems during the rest of your life, and not only medical problems, but also reduced economic opportunity for children and their families. So this is why I'm inspired by this guy, Erasmus, to work on prevention, because I'd rather not have my work be necessary. And of course, because of this, we need to speak to patients, and these are our future patients, the parents, about what they should and should not do when they are pregnant, because that can reduce their risk of preterm birth. But a lot of these reasons for being born preterm or having issues at birth are not within the hospital walls, and they are determined by our environment and by differences in this environment. And why is this important? Well, for this we need data, so I'll show you some data. This is data from the Netherlands of babies being born too small by neighborhood socioeconomic status, so the pictures I showed you before. This is about 13% of the babies are born too small in low socioeconomic neighborhoods in the Netherlands. And in high socioeconomic neighborhoods, it's only 9%. So big differences based just on your postcode. And you see that there are general trends toward, well, a slight reduction in preterm birth over time. But overall, we've not been very successful in reducing inequality. So the next question is, does it help if we change the environment? So this we studied, and I'll get to the heat issue later, in a big national study where we ranked all the neighborhoods in the Netherlands, and there's over 3,000, by socioeconomic status. So here are the lowest ones, and here are the most prosperous ones. And we looked at changes in these neighborhoods over time. Most of the neighborhoods will stay relatively the same, but some deteriorate over time, while others improve over time. Well, that happens every couple of years, or we measured it every couple of years, every 4 years to be more specific. And then we looked at what is the relationship between changes in socioeconomic status and the outcomes of pregnancies of people living in these areas. And we had data on 2.5 million births in the Netherlands. And it showed that indeed in the low socioeconomic neighborhoods, there was the highest rate of babies being born very small. And I'm saying very small here, but the same is true for being born preterm. The tricky thing is that for neighborhoods that were once pretty good, but then deteriorated, there was also an increase in the babies being born too small, which was not there before. Luckily, the other thing is also true. So when neighborhoods improve over time, you see that the birth outcomes also improve. So this gives an indication that changes in our environment can actually help reduce adverse birth outcomes. So that's something that we can do about this. The question is, of course, what? And I'm not saying it's just heat, but it's one of the issues that we are focusing on. Well, I'm copying Jeroen here, saying how important heat is, and I don't have to convince you about that. I do want to mention that although Jeroen showed that low and middle income countries are very much affected, and this is an important point to acknowledge, that also Europe is actually the continent that is warming at the fastest rate. So we are going to be more and more affected as we are here. So how did we study the impact of heat during pregnancy in the Netherlands? Jeroen showed that there's a lot of ways to do this. They all have their pros and cons. And the same is true for ours, which is again a bit different from the ones that Jeroen presented. So I'm going to show a nice photograph here of the people that actually did most work. So this is Lisbeth, who's a former PhD student in the group, who now is an assistant professor in Tilburg University. I was lucky enough that she is a statistician background. So what we did is we combined data from the National Perinatal Registry with statistics data on socioeconomic status of these people. Plus, we also know they live based on postcode. And then we connect that to all the KMI measurement stations in the Netherlands that assess temperature at the day level. And by doing that, we had 2.5 million births over a 15-year period. And for every pregnancy, we could connect every day of that pregnancy to the temperature of the nearest weather station. So lots of data, as you can imagine, but also lots of information. So you can read in the paper that came out during the first wave of Netherlands this year, exactly in June 2025. So we used a bin approach, showing some bin here, just to show you why it's called a bin approach. What we do is we collect temperature of every day in pregnancy and then put them in different bins of 4 temperature degree variation. And then you can see that most of the days during pregnancy, people are exposed to temperatures that we all think are fairly regular in the Netherlands. And we don't consider the Netherlands to be a particularly hot country, and most of us would say, well, above 20 degrees is not very hot. But this is a mean temperature during the day, and these are days that the maximum temperature often goes above 2 degrees. So they are what most of us would consider a hot day. So it really is these couple of days in this highest range. And that's on average during our study period 12 days, but already much more these days. And we compared these exposures to the reference, which is the median exposure in the Netherlands, the mean exposure in the Netherlands. So we used the fact that people in random places in the Netherlands, that you don't usually move place because it's hotter or less hot in another place in the Netherlands because it's a small, very flat country. So we can sort of assume that temperature exposure is random. We adjusted for seasonal effects, regional characteristics, underlying time trends in the outcomes, and other climatological variables. We also adjusted for maternal characteristics and socio-demographic information. And I'll get back to that last bit later. And a nice thing that I think Lisbeth thought of is to also include a negative control exposure, which means that we just assume that the exposure would be after pregnancy, which obviously doesn't make any sense. and showed that there was no certain association whatsoever between temperature after pregnancy and the pregnancy outcome, which obviously makes sense. It also shows there is no or very little bias in the underlying models, if it makes sense. So this is the main result. And as Jeroen also showed, it's not a linear shape, it's actually U-shaped. So there's also some signs that colder temperatures in the Netherlands are not good. What this shows is the additional risk of one additional day of a certain temperature in the Netherlands compared to the mean temperature, which you see here, which is the dot on the black line. You see that the odds ratios are quite small, but that is because it's only about 1 day. So they add up if you have more days of exposure during pregnancy. It's very clear that the highest temperatures give the highest risk of a baby being born preterm. And then if we sort of take these measures and do a back-of-the-envelope calculation, or in Dutch bierfilter berekening, we calculated that during the summer of 2023, which was pretty hot, about 500 excess preterm births would occur because of heat. And if you consider that the Netherlands on average has about 11,000 preterm births every year, that's quite a significant number. And this will increase in the next couple of years. What is perhaps even more worrying is that these effects were not evenly distributed across society. And here you see family income, with these being the most prosperous people and these the people with the lowest income. And you see that the women who were pregnant had the lowest income, had the highest risk of heat-related preterm birth. And this was the same when you looked at education. It was also the same if you looked at neighborhood socioeconomic status. So it shows that the most vulnerable people in our community, who already have higher rates of preterm birth and other adverse birth outcomes, are most affected by heat. And thus, heat will increase the early life inequalities, which are already here, as I showed you earlier. Some considerations about this research. Obviously, no research is perfect, but we had some strengths. It was quite a big study. Even though we're a small country, our birth outcome data in the Netherlands are pretty good. We use this unobserved confounding, like I said, and we don't have a lot of echo, or we didn't have a lot of echo during the study period, so there's not much bias in there either. Some limitations: the small parts of the births could not be linked. There is obviously measurement error because you don't live next to the KNMI measurement station. I'll get back to that later. Because an important aspect of that is the urban heat island effect, which we could not capture. And therefore, we think that our current estimates are actually the lower bound of the actual effect, which might be much bigger than we estimated. Hope this all makes sense. And if not, I'm happy to discuss it over coffee. So what's next? Of course, I feel a responsibility to continue research in this area because it makes so much impact, even in the Netherlands. So this is Meda. She's now working on a regional study. So why are we doing a regional study? Because again, we will use this perinatal registry and Statistics Netherlands data. But we also can incorporate very detailed air quality data. Well, most of you will know that Rotterdam is not the cleanest area in the Netherlands, and there's a lot of measurement stations measuring air quality, which is obviously an important covariate when looking at the impact of heat during pregnancy. So we'll be accounting for that in this study, and we will also use data that will be able to assess the urban heat island effect. Which is important because Rotterdam is an urban area with a lot of concrete and not so much green. And we can compare it very nicely to areas that don't have much concrete and do have much more green. So there's nice variation in the area. And that's important because, well, the affluent people usually live in the nice neighborhoods, and the poorer people live in the neighborhoods with much more concrete and much less green. So we'll be able to assess these effects. And particularly innovative aspect is that we are now probably getting data from one of the big energy suppliers in the Netherlands on routine thermostat data from thermostats that are in people's homes to measure the indoor temperature and link that at an individual level to the birth outcome data. So that's work now on its way. And besides these epidemiological studies, which I always really like, there's one more in between, sorry. So this is the indoor data, actually, from a different study of our collaborators in Delft. And it shows that these are indeed the affluent neighborhoods, and this is indeed the very stony neighborhood with very little green. And this is the average indoor temperature in people's homes in these areas. And you can see very big differences, up to 4 or 5 degrees on a hot day during summer. I was going to come to this. So besides the epidemiological data, I think we can learn a lot from the people themselves. So we are now working on that, and one of the people working on that is in the back of the room, Merel, to actually speak to people who have experienced pregnancies in neighborhoods that are not the best of Rotterdam, to hear how they experience heat during pregnancy. What do they do to cope with heat during pregnancy, and what can we learn from that? And a few preliminary results here. You can find some quotes from these interviews. And I particularly like the third one, which also shows that it's not just heat, but also other exposures influencing pregnancy outcomes in these people. Because this woman liked to stay in McDonald's most of the time, because at least it's cool there. Well, you can't blame them, but it also shows that we need we need other approaches to help these people cope with heat during pregnancy. So we can tell people what they can do in our room in the hospital, what they should do to better cope with pregnancy, with heat during pregnancy. But then what if you live in this environment, you don't have much green around, and there's not much that you can actually do, and the people that rent out your home are not very willing to do something about it. Well, then we need other policies, and one of them is probably just making the city greener. This is a nice Australian study, which is, I think, the only study of its type, at least that I'm aware of so far, which indeed showed also that urban areas have the highest risk of heat-related preterm birth, odds ratio of 1.6, quite big. But this reduces to 1.5 in urban areas that have more green. So they estimated that improving greenness and getting more trees in cities could prevent about 20% of the heat-related preterm births. So this is one of the directions that we might think of when we think of addressing this issue. And of course, this is why I do what I do, not only to show problems, but to work towards solutions. So we're trying to set up a network nationally and also locally to think about these solutions. And it also shows that you cannot just look at health problems from a health perspective, but you need to have a much wider view, and other policy areas like urban planning might have an impact on health outcomes in a positive and in a negative way. So we are working also at a national scale to bring together different ministries around the topic of early life health, and this seems to be getting quite successful now. So back to Erasmus. Well, he didn't have a promising start himself, because he was born as a son of a priest, which was not really a good thing to do when in the 1500s. But still, he's a person that is remembered now. So I think we can learn from him. And this is also why I'd like to end with another quote from him, that when you enter Rotterdam by sustainable travel, namely train, you might see it, and it tells you to, well, where I feel good is where I'm at home. And I hope that we can make that happen for future generations. So thank you for your time, and I'm also looking forward to having discussion later on.
Thank you very much for this clear presentation. We still have 5 minutes to the break for questions. Are there any questions in the audience? Yes, please. Yeah.
Fascinating data, but I had a bit of problem with the interpretation.
Oh, here's the microphone, otherwise people can't hear it. I should not forget. Yeah. Yeah. Yeah.
When in a certain neighborhood, say, let's stick to Amsterdam, Amsterdam North, that was 10, 15 years ago horrible, low socio-economic status that now has hugely improved, but then other people are going to live there. So how does that influence your conclusions about raising the social economic status and then that pregnant women have less premature babies?
Yeah. It's a great question, and I like to be challenged. And it's also one that we obviously considered. So what we did is we analyzed the same data without all the people that had changed home in the last 10 years. And then you still see the same patterns. So it's not about the gentrification, which is, well, a good point. Thanks.
Other question from the audience? Brechtje? Yeah. I'll bring the microphone.
Bedankt, Hein. En mijn naam is Brechtje Daams. Ik vroeg me af of er ook gekeken is naar de leeftijd van de ouders, of daarvoor gecorrigeerd is. Of oudere moeders misschien toch meer preterm birth krijgen?
Nou, in het algemeen is dat waar. Dus zowel hele jonge vrouwen als oudere vrouwen hebben een hoog risico op vroeggeboorte. Daar is inderdaad voor gecorrigeerd in deze analyses, dus dat is niet verklarend voor de verschillen die we zien. Wat niet betekent, en daar hebben we niet naar gekeken, of vrouwen die jonger of ouder zijn, gevoeliger zijn voor die hitte. En dat is wel iets waar we nog naar zouden kunnen kijken. Dus je zou een gestratificeerde analyse kunnen doen, zoals we hebben gedaan voor sociaal-economische status, naar leeftijd, om te zien of de effectgrootte verschilt naar leeftijd.
Can you shortly...
Oh, sorry, I'm
in English?
I'm doing it in Dutch now. So, let me get to the point. So you were asking about age, whether it might influence these associations that we are seeing. So we corrected for maternal age. So we are assuming that it is not explaining the associations what we see, but what might be the case is that there's an interaction with maternal age. So maternal age, the effect of heat on birth outcomes might be different depending on your age as a mother. We did not look at that, but we can do that quite easily with the data that we have, like we did for socioeconomic status.
Yeah, follow-up question. Yeah.
I wonder if the blood flow is less good in elder women probably. If that may be a cause for, but yeah.
Yeah, so it's a good point. So it's actually how I met Hein, because we are hoping to do studies together in the future where we look at these physiological mechanisms, which might indeed be different according to age. And it's quite likely that women who are a bit older have less efficient blood flow to the placenta, which might affect vulnerability. So yes, that is something to look at.
To continue from that question, I noticed that the first presenter, Jeroen, only used singleton babies. My question is there a higher risk for twins? So two heat-producing in the womb? Is there a difference? Is a higher risk for twins than for singleton babies?
It's an interesting question. The reason for just looking at singletons, which we also did, is a pragmatic one, because it's by far the largest group, because singletons only is a couple of percentages of the total population. And they are quite a different population. So they are in themselves already have a higher risk of delivering preterm, just because the womb is getting too big.
Yeah.
So it's more difficult to look at these effects because of this and because the group is so small. So I wouldn't know, but from a physiological standpoint, it's quite an interesting question. And so related to the previous question, I was actually intrigued by Jeroen, I don't know if he's still here, by Jeroen's finding that there was an increase in babies being too small at birth, but also an increase in babies being too big at birth. And the latter, I'm quite intrigued by to know what the underlying thoughts are. Are you still around, Jeroen?
Yes. Is it possible to get Jeroen on the screen if you heard it to give an answer here? It's on hold,
Okay, so I might not.
That's too much. We'll keep that question for later on, the general discussion. Now, right now it's time for a break. We planned about 15 minutes, so please take coffee or tea, and then I expect you back in about 15 minutes. And then we continue with children that are born without any problems. Welcome back. We had a break here, and I hope also at home that you had a short break. We're ready to start again, and I'm pleased to announce the next speaker. The next speaker is Eline van der Kamp, and she will talk about heat vulnerability in infants. The floor is yours.
Yeah, thank you. Good afternoon, everyone. I'm very glad to see all of you being here and as well attending online. To kind of come together and show an interest in this topic of heat and the impact it has on child health. As Hein already mentioned, so I will be talking about heat vulnerability in infants. So the past two presentations were very focused on the effects of heat exposure during pregnancy and what it does to the birth outcomes. And then I want to make the next step and show you what effects it might have once children are born and are in these first few months of life. Before I go into any thermoregulation and physiology, I just want to zoom out a little bit and show you about the rising heat exposure. I don't have to tell you specifically anymore that global temperatures are rising and heat waves are becoming more common, prolonged and intense. But what is interesting is the focus on vulnerable groups. There's always been a focus on certain groups, such as the elderly, as well as individuals with certain health conditions that have received special attention during these heat events. And children and infants specifically have been long left out of the picture. And we more recently see a slow increase in this attention to these specific groups. So for example, on the left here's some data from the Lancet Countdown of their 2025 report that just came out a few weeks ago. And they specifically divided their data and looked at what it meant for the rising heat exposure in infants or the heat wave days experienced by infants per year. And the same goes for the other way around. For organizations that already focus on child health, such as UNICEF, we see that they also start paying more attention to what the effects might be of extreme heat and heat wave events on child health and infant health. So we see from both sides there's a growing interest. And why is that important? I just want to go over some of the studies that have been done, various epidemiological studies in various countries that show that the heat exposure affects health of infants specifically. So this is a study from 2008 already from California, which looked at how the mortality risk would change with an increase in daily temperature of around 5 degrees Celsius. And they divided their results in different age groups. And as you can see, the elderly populations, so from 65 years and above, we clearly see that increased mortality risk, which is well known and well documented that elderly are more vulnerable in extreme heat. But again, also that infant group, we see a significant rise in mortality risk as well. We see similar results here. We've seen quite some graphs in this way already, so I hope you've gotten familiar with them, with the different temperature percentiles. And this is a study done in South Africa, where they looked at over millions of data from people. And again, you see the 65 years old population. Once you go into the higher temperature percentiles, this mortality risk increases. But again, also in the youngest age group, so 0 to 4 years, this trend is visible as well. It's not just mortality risk, we also see it in different indicators such as hospitalizations, emergency department visits, the prevalence of certain diseases, and even in developments. So this recent study from last year looked at a cohort of infants in the Gambia. And what it's noticed is that there was even an effect of heat on the growth in terms of weight and height for age in infants. So it's quite widespread. And then the next obvious question would be, okay, but then what makes it that these health impacts happen? What makes them more vulnerable in the heat? And if we look at thermoregulation, we can broadly divide it into two different categories. On one side, we have behavioral thermoregulation, which is what can we actually do to reduce or avoid heat exposure. And on the other side, we have physiological thermoregulation. So once we are exposed to heat, how does our body respond? And I just want to go over both of these categories with you to see how infants differ and what this means for their vulnerability or for their risk in the heat. Starting with the behavioral thermoregulation, because this is quite unique in infants. Because as you can imagine, infants cannot regulate their own environment. They cannot move to a cooler space or remove layers of clothing or make sure they stay hydrated on their own. They're completely dependent on us caregivers to recognize risk and act appropriately. And once this doesn't happen, it can become dangerous quite quickly, which is, for example, the case with microenvironments. So microenvironments, for example, cars or strollers, are these spaces in which heat can build up really fast, especially if there's poor ventilation and direct exposure to the sun. This can happen quite rapidly, as you can also see here in the visualization of the car. In just 1 hour, temperatures can rise from around 21 degrees Celsius to even 45 degrees Celsius in the car. And especially in the US, we see that a lot of cases happen where children die from heat stroke while being in the car. Since 1998, over 1,000 children have died. And we see that a very large proportion of these children are actually infants, around 31%. And another example I just named were strollers. So strollers are by design already these semi-enclosed spaces. And when parents or caregivers go outside in hot summer weather, they often try these different strategies to make sure there's not too much direct sun shining into the stroller or make sure it's cool inside. And there's been this study from 2023 that looked at these different strategies and investigated what actually happens to the temperatures inside the strollers. And what it found that quite some of these strategies that are very well intended actually increase the temperature in the stroller, especially when you would cover it with a certain cloth, like a muslin cloth. We see here in the red and orange pictures that temperatures increase. If you would wet the cloth and use it in combination with a fan, it can have a cooling effect. But then again, if you don't use it appropriately or the right way, it can have very adverse effects. And not just these microenvironments, you can also imagine that infants cannot communicate to us when they feel too warm. So they're very dependent on the caregiver's perception of their thermal state. And this doesn't necessarily always match. So here they've done a study where they ask moms to carry their infants in a sling on their front, and they would step around for 15 minutes, and then they were asked if the thermal state of their baby changed. And they indicated that the thermal state didn't change, they didn't feel much warmer. At the same time, they looked at the skin temperature on different body sites, and they'd actually see that just in those 15 minutes, there were quite some increases. So just showing that it's not always what you think. So what you see in terms of behavioral thermoregulation, it's really about that dependency on the caregivers, and their perceptions and their decisions and their eventual behaviors. I think this is pretty obvious for infants. Going to the physiological thermoregulation story, it might be a bit less straightforward. Just to start, thermoregulation is all about maintaining a stable core temperature. For us humans, that's around 37 degrees Celsius. And we can tolerate small deviations from this in both directions, but once the deviations become a lot larger, it can have very negative effects and even become fatal. And we as humans, so also babies already, are always producing some heat because of our metabolism. So that means in order to stay in thermal balance, we need to balance this heat production with heat loss to the environment. And there are different ways in which this heat loss can happen. And they're visualized in this picture here. So we have convection, radiation, and conduction, which can be grouped together into dry heat exchange. And they really depend on the temperature difference between the skin and the air around you. And it can go either way. If the air around you is a lot warmer than your skin, you can gain heat. If you yourself are a lot warmer than the air around you, you will lose heat. And then you have wet heat loss, which is mainly the evaporation of sweat. So when it gets warmer, you start sweating, and once it evaporates, it has a cooling effect. And there's also a bit of evaporation from the respiratory evaporation from the air you're breathing out. So if you take all these factors together, you can make a kind of simplified thermal heat balance. So to know whether you store any extra heat, so whether your core temperature will rise or will lower, you have to look at the heat production, the dry heat exchange, as well as the wet heat loss. And there are a few things that are different in infants compared to adults or older children, which make that they thermoregulate different as well. And I just want to go over some of these differences with you and see what kind of effect they have. So the first one is a higher surface area to mass ratio. So what this means is that infants have a very large body surface area compared to their mass, way higher than in adults. It's actually highest when you are just born as a newborn, and then it declines as you get older. So this has a very large role in the dry heat exchange. So when it's, because you have a lot of surface area to have exchange with the environment. So when it's cold, you will lose more heat. When it's really warm, you can gain more heat. So whether it's an advantage or disadvantage, also it depends on the conditions. The second one is the metabolic heat production. So like I said before, we're constantly producing heat ourselves, but the relative amount of heat we produce kind of differs over the years. So this figure shows over a lifetime how that would change. And as you can see, very early on, there's a huge peak of a really high energy expenditure. And this is the period where there's a lot of growth and development happening, which of course costs a lot of energy, but also means there's relatively more heat production. So to balance this increased heat production, we also need to, or the infants also need to lose more heat in exchange. And the last one is about sweating. So when it becomes really warm, sweating will become our main mechanism to lose heat. And once we are born, we're already born with all of our sweat glands. So those are 2 to 4 million, which means that the density of glands is actually highest in infants. At the same time, the size of the glands is smaller in infancy. And a small sweat gland is associated with a lower sweat gland output. So in infants, you have a very high density, but smaller glands. And how does this translate to how much they sweat compared to adults? Well, there's this study done by Suzuki and colleagues in which they had a controlled experiment and they exposed both mothers as well as their children, among which a lot of infants, to heat. And then they looked at the total sweat rate, and they saw that if you standardize it to body surface area, so to square meters, it was actually a lot higher in the young children. So even though the gland output, the output per gland is higher in the mothers, there's still a very active sweat response to heat from a very young age. So to reflect on this, something I often see coming back in both literature as well as policy or information documents is that infants are very vulnerable in the heat because of an immature thermoregulatory system. When I look at these differences, it doesn't seem like there's a lot of evidence to specifically support this statement. I think it's more important to recognize that infants are different. They aren't just small adults, but there's some differences that make that they respond different to their thermoregulatory system responds differently. But there's very limited research actually done in this age group, especially research in controlled environments with different kind of temperatures and different kind of humidities to see how what actually happens there. So that's why a few months ago we did our own study. So together with Amber Klomp, Shonda Morrison, and Hein Dane, we did a study in our climatic chamber here at the FU, just 3 floors up here, in which we wanted to know more about that heat balance that I showed you before and what it looks like in a certain hot, dry condition. So what did this look like? We had 20 infants participating, and this was our setup in our climatic chamber, and we had 2 different trials. So they came to the VU here twice. One day the temperature settings were 23 degrees Celsius and 20% relative humidity. And the other day it was 34 degrees Celsius and also 20% relative humidity. And both trials lasted 90 minutes. So in those 90 minutes, the infant was then placed in the little camping bed, a little crib in the center of the room, with just the caregivers and us researchers right next to them. And over those 90 minutes, we did different measurements. So some of the measurements we did were, for example, skin temperature. We had eye buttons on the skin, but also a thermal imaging camera to look at the skin temperature. We estimated core temperature both by looking at the temperature in the ear, as well on the forehead, on the temporal artery. We looked at the heart rate in 2 different ways as well, and the whole body sweat rate by very simply just looking at the body mass before the trial and looking at the body mass after the trial. So I want to show you some of the results we have. So those are the 90 minutes of the trial. We took the first 30 minutes as a familiarization zone, familiarization phase, and we were mostly interested in what's still happening in those last 60 minutes. So for example, looking at the first graph on the left, we see the temperature in the ear, which is clearly higher in the warmer trial compared to the cooler trial. But it does seem to be a bit wobbly, but not increase or decrease that much more after in those last 60 minutes. Similar things are happening for the mean skin temperature, also clearly higher in the warmer trial, as well as the heart rate also increases. So let me zoom a bit more on the mean skin temperature, because that's interesting. The mean skin temperature in the cooler trial, the 23 degrees trial, was around 32.3 degrees Celsius. And this is quite a difference with the air temperature, which means there's a very large gradient for that dry heat exchange. At the same time, we see that the different local skin sites, they're quite different. So we see that the arms and the feet, they're quite cold, and more of the core and the head, they stay warm. Well, this is also what you would expect if they can thermoregulate effectively. Because once it gets colder, you want to keep your core stable, so you reduce the blood flow to your extremities to remain in thermal balance. If we then look at the warmer trial, we see that the mean skin temperature was 34.5. This is the difference between the skin temperature and the air temperature here was very small. So that means that dry heat exchange, or the opportunity for dry heat exchange, became a lot less. At the same time, you see that all the different local body sites become much more alike, much more uniform, which is also what we would expect when it's warmer. In order to still lose a lot of heat, you increase the blood flow throughout your body, through your skin, so there's more room for exchange. So this shows that these mechanisms seem to work pretty well in children under these circumstances. But also, if there's less opportunity for dry heat exchange in the warmer trial, that means you need to lose heat another way. And the other way was by starting sweating. So here you can see the whole body sweat rate, and you can clearly see that for all the participants, they increased in the warmer trial, meaning they really has an active sweat response from the youngest infants as well as the older infants. So this are a kind of an overview of all the results together. So those are taking into that heat balance I talked about earlier. And again, you can see for the dry heat loss that it's very warm, very high in the colder condition, but diminishes in the 34 degrees. At the same time, the wet heat loss increases a lot in the warmer condition. And how does this translate into the eventual heat storage? Well, as you can see here, we didn't find any significant differences between both trials in heat storage, and they weren't different from zero either. So we didn't find any evidence that in either condition they actually gained net heat or lost net heat. So what we then would conclude is that under these controlled conditions, of the 34 degrees Celsius, 20% relative humidity, they were able to thermoregulate effectively. And this was mainly done by increasing that wet heat loss, so by really having that active sweat response. So they were able to stay in thermal balance. Well, that has multiple implications. One of them is that what we still hear every now and then is that they say babies can't sweat, or babies rarely sweat, but they do, as I just showed you, which means that adequate hydration is very important during hot summer weather. But also having the opportunity for the sweat to evaporate. Because if you're just producing sweat but it doesn't evaporate, it doesn't have a cooling effect. So that means things like having breathable clothing, but also when you would wear your baby, that it would also have some room to evaporate that heat. At the same time, you can ask yourself, okay, what does it mean if conditions are changing? So these conditions were fine for the infants. But what if the humidity increases? Because if the humidity increases, that evaporation becomes limited as well, which can become dangerous quickly. But also if the temperature itself increases. As I told you before, they have this very high surface area to mass ratio, which means both dry heat gain as dry heat loss can be more rapidly in infants. So higher temperatures might become dangerous more quickly for this age group specifically. But then what exactly are those thresholds when heat gain exceeds heat loss? Those remain unclear, so we need more research on that. Of course, we cannot research the threshold specifically, but we need to find innovative ways to still get more knowledge on their thermoregulatory system and how they respond in those different conditions. So to get back to where I started, are infants at risk in extreme heat? Yes, they definitely are. A lot has to do with their dependency on these caregivers. When we look at them physiologically, especially their physiological thermoregulation, they are different from older children, different from adults, which means some conditions they might have an advantage, some conditions they might have a disadvantage. And at the same time, there's still a lot we don't exactly know. But what I do want to root for is that when we talk about these vulnerable groups or at-risk groups in the heat, that we don't forget about infants and children, that we provide better guidance for caregivers about what they can do, what they should not do, because there's still quite some misconceptions, it seems. So even if we don't have all the answers yet, I do think we definitely can already provide some guidance to protect our infants. And that's all I had for you today. Thank you.
Thank you very much for this clear presentation. There is time for some questions. Is there any question from the audience to start here? Yes? Jochem?
Very nice presentation.
Oh, I'll give you the microphone.
Oh.
For the others, yeah.
Very nice presentation, thank you. If I remember correctly, the babies were exposed for 90 minutes. Could you, because usually a heat wave in the Netherlands lasts for 5 days. How would that translate, those 90-minute findings, to a heat wave of 5 or more days? Can you say anything about that?
That's a great question. I think showing that it can already stabilize a bit over those 60 minutes is a good sign. So that means a longer exposure, they might also be able to thermoregulate effectively. I think it's especially when it comes to other research I've seen where they, for example, still see a increase in core temperature over that shorter time, over those 90 minutes, for example. And they say like, oh, they cannot thermoregulate effectively. At the same time, we see that stabilizing things like core temperature can take hours. It doesn't need to be that quickly. So I think we need to be careful with interpreting findings from these shorter heat exposures. But it's a good sign that it seems to not increase more in that short of a time.
In line with your question, are there any plans to look at more days exposure to heat for babies?
That's a great question. Yeah, so indeed, we're actually working on a follow-up project at the moment, because one of the questions that also remains unanswered is whether infants can actually adapt or acclimatize to heat. So, for example, for adults, we know that if they're exposed to heat for multiple days in a row, if we compare the first day to day 5, 6, 7, they can handle themselves better. We don't know if these responses occur in infants as well, which would of course be very important to know, because where would be the highest risk? Is it if the heat wave is just starting, or is it during the whole heat wave? So we're hoping to find out more about that soon.
Thank you. Ilse, you have a question?
Yes, thank you for your talk. It was a little bit of a follow-up question, because since this is more of like acute a reaction to heat, were you able to monitor any changes in acute behavior? Like, did the children move more or maybe move less since they also sweat more?
Yeah, that's an interesting question, and that's also what we wondered when we, for example, looked at the metabolic heat production. So I didn't talk about it specifically yet, but as you can see, it was quite a bit higher at the cooler trial compared to the warmer trial. So one of the hypotheses we had for this is that maybe in the heat they just become a bit less active as well, slow down a bit, and lower their metabolic heat production.
Thank you.
Yeah. Jasper?
Well, you looked at them via cameras, right? So you should be able to get that data from there.
Yeah, we were actually discussing this as well, whether it would be interesting to analyze those video recordings specifically and have a closer look at their behavior. So we didn't do that in detail yet, but also, for example, whether their body position would change. So, for example, if it's cooler, they would close down a bit more, and when it's warmer, they would spread out. So there's definitely some video recordings in which we could take a look at that, but until now we haven't in detail.
Yeah, I'm aware of several people using AI to analyze such videos, so it might actually not be that much work.
Yeah, it would definitely be interesting to add to it, yeah.
Yeah, we have that hypothesis that babies, when they're warm, they're spreading their arms. If we can check that, that would be nice.
And then they might reduce their movement as well, right?
Yeah. Is there any burning question from the people online? No, no. They think, okay, we ask good questions. I have one other question. Although the group is small, is there an effect of age in the sweat? You showed that there's quite some variability in sweat rate. Is it related to age?
We didn't see a small effect of age as well. So the infants that were a bit on the older side did have a higher sweat rate as well, which is interesting because there's some other studies. I don't have the graph of it now, but another study that looked at children of different ages as well, so infants, but also 1-year-olds, 2-year-olds, etc., and compared the sweat rate there. They did not find a significant effect of age, but indeed we did see a small one in our group. But again, this might have to do with increased activity in the group that's a bit older. Yeah. So we don't know yet.
Thank you very much. Then we move on to the next speaker, and I have the pleasure to announce a speaker originally from Canada, but now lives in Slovenia, Shondan Morrison. So it's an international symposium that we have here. And she will present a little bit more on children that are a bit older, in childhood. Shonda, the floor is yours.
Thank you very much. Everyone can hear me all right? Thank you to the organizers for this wonderful opportunity to speak to you today. The first 3 speakers have done an excellent job characterizing the issues that we face, that it's not just regions in the tropics that are suffering from excessive heat, but it's actually everyone's problems. And some research done from the Imperial College London in this summer's heat wave found that 2/3 of the heat deaths occurring in London were attributable to climate change and were greater than what was occurring in previous years. Lately, as an exercise physiologist and thermal physiologist by training, I'm interested in studies that are looking at physical activity or work or occupational health strain. And research from Vanos's lab, communicated in Nature Communications a few years ago, was looking at modeling a physiological effect to assess human survivability and livability. And they did a fantastic job looking at differences in metabolic work rate, in METs, and whether or not age had an issue in terms of the activity levels and heat health risk for temperature and humidity. And they did this in adults, this modeling, and also for people over 65 years old. And so my question is, where are the children in these models? We have very little data, empirical data, to look at what happens to their exercise, their work rate, and how that thermoregulation balance is stressed. A lot of the research has been done in the 60s, 70s, 80s, and 90s, but dropped off significantly over the last several decades. So as we mentioned before, we know that they're a vulnerable population, children, and the World Health Organization characterizes children from the ages of about 2 or 3 up to age 10, and then adolescents from age 11 to 18 and more. A very fantastic study from Notley et al. Was published in MSSE, and they were looking at the theoretical issues associated with the maturation process for children and its effects on their thermoregulation system. So we heard how infants do sweat, and that it's an outdated model to say that children are at greater risk because they cannot thermoregulate, but it's true that their body surface area, their changes to skin blood flow patterns, their differences in VO2 peak or their oxygen consumption, and even something like the mechanical efficiency of how they're moving may affect the heat production that's occurring in their bodies. So several years ago, I reached out to Hein Dannen to look at these effects because it was becoming clear that children were being left out of these policy documents. And we know that climate change is multifactorial in nature. So we have the direct effects like droughts and wildfires and floods, and of course high heat. Indirect effects like the urban heat island, air quality, active play environments, and this is also for aeroallergens, changes in disease vector patterns. So a project like Go Hot is really important because they're looking at air quality and heat in combination. And again, as a thermal physiologist, I'm most interested in how do we decrease our risk of heat illness and increase our fitness levels, which build resiliency. So we know now that excessive heat is a health and a public health priority. You've got the International Labour Organization, the UN, a lot of these different governmental and non-governmental organizations like Save the Children are all very concerned about heat and what that means for human productivity and how to thrive in this hotter environment. And in fact, the latest heat strategy published by the WHO for the first time ever, they elevated climate change as their #1 escalating health threat worldwide. So this is more than vaccines or hospitalizations or financial issues and equity. It's actually how are we going to respond to this global crisis. So the rationale for this talk, we already know quite a lot in this research area, because as I mentioned, it was very active many decades before. We know that the younger children do tend to thermoregulate differently than adults, so not worse, but slightly differently as they're maturing. That thermal comfort and sensation are not well delineated in children because most studies have not asked them, how hot do you feel? What could you do? So moving from infancy into young children, children in daycare situations or care, and school systems. We know that more than 80% of children 6 to 17 do not meet World Health Physical Activity guidelines. This is very concerning because we know that highly fit individuals can tolerate high temperatures better than unfit people. And children are classified as a vulnerable population, not just because of physiological purposes, but like we mentioned before, because they are lacking in the public health policies and they can't really make their own decisions or advocate for themselves. So I had the great pleasure and privilege to be working for the past 2 years in Singapore, and I'd like to invite you to the future because as we know, Singapore is very hot almost every day and very humid almost every day. We know the problem, of course, and the last 3 speakers have really delineated that well. It's only going to get worse, and especially in different regions of the world, they are facing individual problems, but heat is a common factor. And in a place like Singapore, the urban heat island effect is very real and very measurable. At the School of Medicine, when I first arrived, perhaps I had certain expectations going there. I thought it might be very rigid or very strict or very strong, and it is all of those things, of course. It's Asia's #1 medical school, and they have over 100 years tradition of excellence, so it was very intimidating and very inspiring. But what I really loved was their website, which showed that they were value-driven, and they really want to transform how the world thinks about any given topic, and they want to attack these problems through a dynamic and future-oriented multidisciplinary program. So even someone coming in as sort of a short-term expert, this really filtered and left a big impression on me. Singapore has moved very quickly and rapidly to being a world leader technologically and through healthcare. And I found that driving that type of innovation required open minds, long-term vision, and political will. So what is step 1 for a place like Singapore? The principal investigator of all of this work is Jason Lee. He's really involved and heavily motivated to help people in the region dealing with heat stress. And as I mentioned before, we know that Singapore is hot. It's always been hot. Up until 3 years ago, they didn't even have a heat warning system. But even in places like Singapore, they're finding the variability in temperature is occurring more rapidly. And so they're facing higher heat days for longer. And so even for their populations, they're not used to this, especially for the elderly and other vulnerable populations. So they developed a heat health weather advisories, and we're implementing that during my time, looking at low heat, moderate, and high heat, and what pregnant women or elderly or children and infants should be doing under these circumstances. The reason I was brought on board was to be a technical advisor for a project called Cooling Singapore 2.0, and they had various work packages looking at green spacing and dealing with the urban heat island effect, but for the first time ever, they had a work package dedicated directly for humans and human physiology. So that we had 3 different arms of a similar study, which was looking at older adults, heat unacclimated adults, so people that were potentially tourists coming to Singapore for various events. They wanted to make sure that people who were not used to this hot, humid environment were not, shopping one day and then feeling ill the next. And then the children. So we were looking at the children aspect as well. This is like a pilot trial slide. It's not completely accurate, but it was just going to give you an idea that this was a repeated measures crossover design study. So we brought people, children, older adults, whomever, into the lab. We got them wired up with heart rate, beat by beat blood pressure, skin temperature, sweat rate. They were at baseline for a time. And then we had them exercising in the heat chambers for 60 minutes at either a lower VO2 peak, 40%, or at higher intensities. But we wanted to make sure that the project was ecologically valid. So we didn't control for the amount of heat that the body was taking in, like heat storage capacity. We just had them exercising at a relative low and moderate amount to simulate going out of your house, walking to a bus stop, going out of your house, doing errands. We wanted to make sure that the information would be accurate to the population. So they exercised for 1 hour, and then we took post scales and weight, and what did we find? Well, we found that pilot testing was very fun. These are my 2 children in the center panel, testing the different equipment, and then we have the trials underway with solar panels and wind airflow and measuring all of the good stuff. What did we find? Well, the measurements are still being analyzed, so I can't tell you very much at this point, but we can say that there were 16 prepubertal children who finished the trials, and it was done across 3 of the temperature conditions stratified by Singapore's wet bulb globe temperature, so low 26 degree, moderate 32, high 35. Obviously, these temperatures are much higher than the Netherlands or elsewhere, so one area is low, can be another, so your 26 degree is obviously high for here. Heart rate, estimated core temperature, whole body sweat rate were monitored throughout. So stay tuned for this space for data forthcoming. Meanwhile, I wanted to reach out to colleagues and international experts in exercise and cardiorespiratory fitness, because as I mentioned, exercising is really good for all of that heat, acclimatization, cardiovascular function, etc. And these researchers, Grant Tompkinson, Justin Lang, Mark Tremblay, they're world experts in child cardiorespiratory fitness, and they found several years ago that there are international trends decreasing in cardiorespiratory fitness for children from 19 different upper and middle income countries, from 1981 to 2014. So I reached out to them because I wanted to see if changes in wet bulb globe temperature during that time may be correlated to this decrease in physical fitness. These are the countries that were involved in their original study and database, where they were collecting 20-meter shuttle run data from almost 1 million data points around the world. And these axes are reversed, so please wet bulb globe temperatures on the other side for this. I pulled data specifically from the Netherlands for you today, and we were looking at changes in wet bulb globe temperature, that daily mean maximum, and then the cardiorespiratory fitness is decreasing in the Netherlands. For all sexes, all countries, this is what the combined graph looks like, an increase in wet bulb globe temperature and that decrease in change in the VO2 peak estimated for these children. And we found that for every increase in wet bulb globe temperature, there was a corresponding decrease in this cardiorespiratory fitness, and it was across all 19 climatically diverse areas. We're still writing up some of the data, so please keep this confidential, but this was consistent across all sexes and So we were very interested in this direct comparison. Of course, we really cannot speak to the mechanisms at this point. It was more of a proof of concept. What about what happens in seasonal locations? So I'm coming to you from Slovenia, and here we were doing some research looking at what happens to children's physical activity behavior patterns across the seasons. This work is done by colleagues from Canada and Australia. They were looking at daily minutes of moderate to vigorous physical activity and comparing that to their sedentary behavior. And we see that across these maximum temperatures seasonally, that in Canada, for the Canadian sample, their minutes of physical activity kind of bottom out, or they plateau as the temperatures get higher. And for Australia, as those temperatures get higher, the physical activity decreases. So you have a nice zone here between around 5 degrees and 25 degrees where children remain physically active at higher intensities, and above or below that, it's not so optimal. This is research from McGarrick et al. A couple of years ago. They were hired by the Government of Canada to look at unstructured outdoor physical activity in children. They had children, they were monitoring children for 4 hours who were playing outside. There were no other instructions. They were just free playing. They found that the children significantly dehydrated. They were hypohydrated at the end of their 4-hour session. And I'm sorry for the graphs being very small, but it's basically differences in body core temperature from baseline and the wet bulb globe temperature ranging from about 12 to 32 degrees. And they found a significant correlation there between the wet bulb globe temperatures and the body core temperatures of the children. So it's just evidence that children play. When they play outside and it's hot, they get hot. And so it's very important from a public health messaging perspective that that we as adults know that. It's not necessarily a bad thing, though. As Hein Dannen was mentioning, we want to see those physiological improvements. We don't know how children feel in the heat very well, and whether this affects their body heat storage capacity. So usually for adults, we feel hotter, or we start sweating, or we start shivering, and then there's a behavior that happens. You stop playing, or you put more clothes on, or you drink water. And so we don't know if the sweat onset or thirst sensation or some of these key behavioral thermoregulation aspects are slightly different in children. During the COVID-19 crisis, we could not perform lab experiments, so I reached out to Canadian colleagues Nathan Morris and Nick Ravanelli, who are very involved in this topic, and we devised the first questionnaire to look at what is happening within the family unit when a heat alert is broadcast. We called it the Active Heatwave Project, and we basically sent out email communications to people in Slovenia, the USA, and Canada. And there were questions on physical activity, physical fitness, thermal comfort, sensation, thirst, and heat management strategies. So to our knowledge, this was the first time we were looking at data in a family unit. And we found that, interestingly, the children under age 10, under age 18, were more physically active or reported more physical activity minutes than their adult counterparts. But they did not differ in terms of their sedentary behavior times. And of course, the young children were sleeping more, as they should, meeting those 24-hour movement and health recommendations. So the children were sleeping more than their adult counterparts, and they were moving more. However, thermal sensation, thermal comfort, and thirst sensation, there were no differences between the different populations. This sample was quite small. It was just under 400 participants total, so it would need to be replicated on a much larger scale. But again, this was a proof of concept to see if we could monitor or question people on their behaviors during an actual heat wave. Back in Slovenia, they have an incredible system looking at annual fitness testing in their children. They do this in the school system. They have a battery of 11 fitness tests that they measure from the age of 6 to 19. And then once every 10 years, they have a decennial study, which is looking at the same type of things. So musculoskeletal strength, fitness, flexibility, questionnaires, etc. And again, I found out through my colleagues that the cardiorespiratory fitness, the run portion of this exercise testing, takes place every year outdoors. So we pulled the data from the closest weather stations in the years where this data was being collected, and I was working with some statisticians to ask the simple question: when the children are running outdoors, and the UTCI is increasing, is that affecting their run performance? And in fact, we found a significant interaction effect that for girls and boys at the youngest age 6, there is a measurable difference as UTCI increases, and you're getting near that 25 degrees Celsius, the children are running slower. But in the older cohort, the kids that are 14 years old, there's no significant correlation to outdoor temperature. These runs are very short, 600 meters, so it could be more exacerbated with the longer you run. In terms of climate change and indirect effects, we have the global pandemic that occurred where everyone was in the home, and this is causing a lot of problems in terms of inactivity. We were looking at the effects of pandemic movement behavior policies on children's physical fitness, activity, screen time, and sleep. And so this is MVPA, moderate to vigorous physical activity measures in children in 2018 and the same in 2020. For both boys and girls, and we can see a significant decrease in the total minutes being performed when the guidelines are being enacted. So this caused the team at the Faculty of Sport to create something called a barometer of public health engagement. They were taking all of the information that we knew in terms of government policies and ranking how this was going to affect child health and especially their ability to remain physically active. So at this point in time, it was ranked very poor because the government in Slovenia was redirecting funds that were earmarked for child fitness or PE programs in schools and putting it elsewhere. They were also closing things like playgrounds or gym access at the time, which made it more difficult for people to remain physically active. So it's really important that countries are able to detect changes in physical activity and physical fitness. And this is an example of the Slovenian system where, as I mentioned, they have a battery of 11 different fitness tests, and then they have created this index, the physical fitness index, based on those results. This is boys and girls and the beginning of their national fitness database, which encompasses over 30 birth cohorts and over 8 million data points. So there's the independence of Slovenia. You can see, I have a laser, this is great. You can see that over time, throughout the 1990s, there was a significant decrease in physical fitness in their young population. And this allowed the justification for the researchers to ask for an intervention program in schools. This is the Healthy Lifestyle Intervention. And it caused an increase of 8% in physical fitness for both sexes. It was a 5-year program, and it was offering an additional 1 to 2 hours of guided PE in different classrooms around the country, and it had a significant, obvious positive impact. The point I wanted to make here was they were able to test their children in April and May of each year, and so in 2020 and 2021, they were able to record a 30% decrease overall, the largest decrease ever observed in this physical fitness monitoring program. And you may wonder what happened afterwards. Sorry, this is from a different report, and it's like an epilogue, but you can see there is a rebound effect, but it doesn't return back to where they were before the pre-COVID times. So the experts at the Faculty of Sport are hypothesizing that this group of children will remain lower than the other peers for the duration of their childhood. So when we're talking about counteracting climate-related inactivity, and you're looking at different places or regions or peoples, I think that it's really important to consider the cultural aspects, because it might not be possible to do huge hikes out in the wilderness or muddy puddles. It might be more structured, or you might be in areas that are completely different from where we're thinking. In Singapore, for example, they have a really great community and environment where they have infrastructure dedicated to child physical activity and fitness, but the scoring that is occurring for active play, overall physical activity is very low. And this may be because there are missed opportunities due to environmental influences, like it's just too hot or too rainy or too humid. And there's often a cultural perspective that we need to consider, because there is a prioritization there for different disciplines away from physical activity towards mathematics, languages, and studying. So this work has been done through the Active Healthy Kids Global Alliance, and I'll talk more about that in 1 minute. Work from a PhD student that I'm co-supervising in Singapore. Vanessa Tay has looked at physical literacy in school children in Singapore. And I know this is a busy slide, but just so you know that physical literacy is sort of like reading literacy or any other type of literacy made up of different components. Physical literacy has a motivation and confidence component, a knowledge and understanding, like do you understand why it might be important to move your body regularly? Do you have the motivation and confidence to do so? Like, would you just choose to go outside and play with some friends or go for a walk or a cycle? The physical competence to take care of your own body and run, jump, all those fundamental movement skills. And then overall physical literacy. So the point I wanted you to see from these slides is that the majority of the Singaporean school children, age 11, up to 94% of them are in the beginning and progressing stages. And those are the stages that are not associated with adequate health outcomes. You need to be at the achieving or excellence level in order to see those decreases in risks for obesity, risks for diabetes, etc. later in life. These results were independent of household income and maternal education levels, so even though we do see significant differences with income, it's not enough to move the needle out of one of these physical literacy zones. So this brings us to the model that I was creating several years ago, trying to tie in all of these concepts and advocate for more physical activity and fitness, especially in children and in the context of climate change, specifically the heat. And of course, we need to build a foundation of 24-hour movement behaviors. Physical activity is made up of different indicators. You have sources of influence like your school, your community, your government. You also have behavioral influences like organized sport or active transportation, sedentary behavior, and sleep. So these three concepts all together are a 24-hour movement behavior. And this is the foundation for active, healthy, lifelong living. You need to have a minimum amount of this because you can do a lot of physical activity and have it not affect your physical fitness in any way. But physical fitness is heavily influenced by the physical activity you do. Physical fitness is health-related, skills-related, and has a future health outcome component to it. And all of this feeds into that physical competence part of physical literacy. And so I would argue that you need to be physically literate to be confident in how you move your body, do so regularly in order to adapt to the challenges of climate change. And this includes allergies, mental health, and extreme temperatures. So what are we going to do about this issue and bringing it back to heat and prevention. There are 3 global initiatives that I'm involved with that I'd like to mention to the team here and to the people online. The first is increasing physical activity monitoring on the global stage, specifically for children. And this is what the Active Healthy Kids Global Alliance has been doing for the past 10 years. There's a global matrix that occurs where countries will grade their own region based on different indicators. And the people in charge here in the Netherlands, Tim Takken and myself in Slovenia, we basically take all of the evidence over the last several years and produce report cards where their different indicators are graded A, B, C, D, etc. And they're used as policy documents and evidence-based initiatives. We recently published a spotlight in British Journal of Sports Medicine, which has been celebrating the last 10 years of this initiative. And in this initiative, there have been over 230 publications, cited over 7,000 times. There have been almost 400 presentations around the world. So it really is a great and growing network that is advocating for physical activity of children. The second is a research project that was launched by and led by the Faculty of Sport, University of Ljubljana. It's called FitBack. This is a project specifying physical fitness surveillance, mostly in Europe right now, but it can be expanded to around the world. There is an online web portal where you can monitor the fitness of yourself, or PE teachers can do it at the classroom level, or you can even use the skills and the resources here to create a fitness surveillance monitoring system at the national level. An interesting part of the web portal is this section. It's the European fitness map, where you can choose which tests you would like to look at. So 20-meter shuttle run, or standing long jump, hand grip, body mass index, or waist circumference to various countries around Europe. And you can choose which centile or the percent of fit or unfit children are meeting these standardized fitness tests across Europe. The third one, looking more at resiliency, and something that I am really interested in, is outdoor active play and risky play. So having children across their childhood continue to be outdoors, even if it's windy, even if it's rainy, even if it's slightly warm. And this is the mantra of Outdoor Play Canada, who have a conference that they've launched called Breath of Fresh Air. The conference takes place outside. All the researchers present outside and around a fireplace in Ottawa, Canada. And I bring this up to you now because this year they recently launched a 2-year endeavor, an update to their 2025 position stand on active outdoor play. The first one was created 10 years ago and caused a huge explosion in the research area. It was also cited in a landmark case in Canada where someone fell off a playground, a small child, and they broke their arm. And the parents tried to sue the British Columbia government for negligence. And so it's a real concern, though, in many parts of the world. Like, you have children, again, physical competence, like how competent are they at moving their bodies, making decisions, especially at younger ages. And the one of the lawyers put forth evidence from the report cards and from Outdoor Play Canada showing that there was nothing really wrong with this. They were playing a normal game at a normal time on a normal slide, and they just happened to fall off, and that this was not like a negligent act. It was essentially part of childhood. So they were really not pleased, but they were very the researchers very happy that the research they were doing was put towards a positive effect. And so this this position stand was Canada specific 10 years ago, and the 2025 one is now global. The first step, of course, was to create a like-minded language to discuss this, because researchers in this area are very diverse. And so they created like a review article, position stand on terminology, taxonomy, and ontology for describing in a better way, like how do we talk about play. For example, it's really hard to understand or research play in adults because we don't call it play for adults. It's recreation or sports or hiking or outdoor activity. So there were a lot of words that needed to be harmonized in order to make this a global initiative. And in part of this 2-year process, the team came up with this model that was just recently published. And it's looking at all the different aspects involved in the benefits and risks of outdoor play. So there's social capital, there's education and learning, there's movement behaviors, there's a One Health approach to it, human rights and policies. All of this can feed into the UN sustainability goals. There's community and connections. And I can tell you now that the background of research to creating this model included over 18 international reviews, and those are all in the process of being published now. Several are out and more are forthcoming. As an epilogue, I just wanted to thank again the organizers. We're coming up to the 1-year anniversary of the inaugural Southeast Asia Heat Health Forum, which was created by the Global Heat Health Information Network. They launched a node, and they're going to launch more worldwide. And it was one of the first large forums that put child health on the agenda, so I was very pleased about that. They also had a huge distribution in the local media. They took out pages in the newspaper, and so I'm very thankful for the opportunity to talk to you today. I wanted to thank everyone as part of the Go Hot project, especially Dr. Danan for this invitation. Everyone from the NUS School of Medicine, and here's myself with some other scientists and daughters walking around. It was very hot. The team from the Slow Fit and Fit Back, the Faculty of Sport, Ljubljana, and international researchers, especially those associated with Active Healthy Kids Global Alliance, Outdoor Play Canada, and once per year we are organizing a Global Youth Fitness Forum online where we bring together researchers from around the world to network and discuss the ongoing topics that are included in this conversation. The next one, it's always the first week of September. Finally, my background, I got the stripes from this great website, Show Your Stripes, where you can download information or look at the temperature changes in your region, either globally or nationally. And so here are the temperature changes from 1850 to 2024 in the Netherlands. And my last acknowledgement is to my first mentor at the University of New Brunswick in Canada. This is the oldest English-speaking university in Canada, established in 1785, which is surprising to most people that there's a university established in Canada that early. But this is where I did my undergraduate work and got heavily involved in thermal physiology. So I just wanted to thank him, who sadly passed away many years ago, and our first paper together looking at the changes in neuromuscular function with passive heating. So I just wanted to thank him for that and for the legacy of having thermal physiology back on the agenda. That's all.
Thank you very much, Shauna, for this wonderful presentation. I want to invite all the presenters here in front so that the audience can see us, and then we'll go over to the general discussion. Maybe first a question about the last one. Yeah. Yes. Yeah. Oh, I give you the microphone. No, here's the microphone.
Yeah. Thanks very much, Sean. That was a very interesting presentation. I was intrigued by that graph you showed of physical activity in Slovenia. And at a certain point, it started off the boys were fitter than the girls. And at a certain point, that changed, and especially through that intervention. And I was wondering if the change was already occurring because of increase in literacy, that physical literacy you're talking about, changes in, I don't know, emancipation, social, cultural changes in Slovenia, or through the intervention intervention, if that was targeting girls. So I was intrigued by that. And then, sorry, that was my first question. And I just had another one at the end, because you were talking about that whole active kids program in Canada and being outdoors, and I was wondering if they're also looking at factors like changes in the microbiome and how that might change, allergies and in the future. And then you showed that one circular graph, so I thought maybe you are looking at that, because I saw that nature was in that circular diagram.
Okay, I'll do my best. That's a lot. The first one regarding the fitness database in Slovenia, the intervention did not target girls specifically, so this was something school-wide and nationwide. The differences between the sexes or genders I don't think has been looked at specifically, so I can't comment directly on that, but what I can say is that Slovenia is a very interesting case study, because they have gone through a lot of social transitions very rapidly and in succession. So going from, in terms of politics in the 1990s, from the social system in Yugoslavia to then the more capitalistic society, that in turn created nutritional issues, because there was a lot of Western style food that was coming in over the 1990s and 2000s. Then you had the technological issue with smartphones. First smartphones were 2009, and so there's a huge technological issue. And in each of these epochs, the physical activity and physical fitness specifically never rebounded back to pre-levels when they were measuring it in the 80s and 90s. So this is the best answer I can give you on that question, was that it could very well be a function of changes again in societal norms.
It looks like the girls actually was increasing.
The girls are increasing a lot, and they have such strong physical activity and physical fitness interventions, especially in schools, that I do know that the physical fitness of young girls in Slovenia, they outrank boys in Portugal, for example, in terms of like standing broad jump. So you have like 11-year-old girls outperforming 13-year-old boys in different areas of Europe in there. Yeah, so it could very well be that but I don't think there was a targeted intervention, as you asked. In terms of the second one with Outdoor Play Canada, anybody can join Outdoor Play Canada. It's a nonprofit organization. You can go onto their website and join and get newsletters and be active. They have a board of directors, and it's an entire thing. So they have recently branched out to become more global, and you can get more information on that.
Okay. This is especially interesting, I think, for the four students here from the Applied University of Amsterdam, who investigate playgrounds in the heat. So good that you establish contact. Yeah. Other questions or remarks? Yeah, Brechtje, can you hand the microphone?
Yes.
Yeah.
Hello, thank you. My name is Brecht Daams. I'm an ergonomist specialized in babies. And I may have another explication why the condition of children goes down after 1999, because there are a lot of baby products on the market that are either very unhealthy for children or that are used in the wrong way by parents, especially since around the 90s. And children are very often strapped to these products. Babies are put in sort of seats, reclining seats, and this is very bad for their health. And I'm sort of campaigning against that. And yeah,
you wrote a book about it, Brechtje.
Yes, as well. I've got one with me, a very small book.
Yeah,
yeah, for parents who want to raise their children in a better way.
Thank you, Brechtje. Nice information. Any other questions from the audience online? Did you have an eye on that, Amber? Yeah, can you?
Okay, there's one question from another Eline. Eline, you stated already in your presentation that we should not assume impaired thermoregulation among infants, as your study also showed no proof for that. First question is, what about preterm birth and thus thermoregulation among premature babies? And second question, the same is said about pregnant women. Very often an impaired thermoregulation is proposed as a pathophysiological pathway. What are your thoughts on this?
Yes, thank you for the question. So first, just to emphasize that everything I talked about in my presentation when I talked about infants, they were always term infants. When it comes to preterm infants, the story can be quite different. So for example, when I talked about the sweat response, this sweat response is already present at birth in term infants. But if you're born a few weeks earlier, it may be that this sweat response is not present yet. So in those terms, you can definitely say that the immature thermoregulatory system is not the case for infants, but it might be the case for preterm infants. So it's definitely important to make that distinction. And the second question was about pregnant women and their thermoregulatory system. I'm no expert on this yet, but I definitely think there are they do seem to also have characteristics that influence their thermoregulatory system. So for example, their heat production increases, so that also means they need to lose more heat to stay in thermal balance. There's also, of course, a lot of blood flow going through the placenta, which also means there might be less blood flow left for going to the skin surface to cool down, which I think is now an hypothesis. I don't know if there's any research on that.
I see Jeroen nodding. Jeroen, can you add to this?
Well, I'm not an expert in this, and I just there's a lot of controversy about thermoregulation in pregnant women, that actually they can thermoregulate, and there's a lot of discussion on this expert. I cannot answer this, so I think it's more complex that they actually can. Another thing is that when they are exposed to really extreme temperatures above 40 degrees, then might be different. But I don't dare to answer, but I think it's a controversial that's not clear yet.
But it's one of the topics in the European project that you mentioned, eh?
Yeah. I should have been more careful in saying that. But I know that some experts that are more into this field, they usually say to me, you should not say that. So
okay,
yeah.
good to
There
know.
needs more research about it.
Yeah, and that's being done now in the High Horizons project. Is that true? Or is it still open for research? Is that a topic in High Horizons or not?
No.
Not.
On
Okay.
thermoregulation or physiological response, no. I think there are other studies. Maybe Jasper knows more, but not that I'm aware of it.
Well, there's this study from Ollie J. When I think you also work with him, right? That put pregnant women in a climate chamber under heat conditions, and then had them do low-level intensity training, and actually their core temperature was even slightly lower than non-pregnant women. So I was quite surprised by it. Yeah. So it might not be like everyone says, that their thermoregulation is in fact bad, but then we still don't know why they have a higher risk of adverse pregnancy outcomes.
Especially in the third, Jeroen showed that especially in the last part of pregnancy there are problems. So then you wonder, is it you had a short discussion here with Ger also, is it the baby or is it the woman that is that's having a problem?
Or the placenta.
Or the placenta,
Which is also a system on its own.
Oh yeah. So that's open for research then.
Definitely.
And it's also your ambition, to...
Well, that's what why we've been in touch. So we have a grant application out to do joint studies in this field. Hope for some positive responses there.
Hope so. Are there more questions from the online audience? No? Is there more questions in the room? Yes. Jantine, you can introduce yourself. The microphone goes to you, so that everyone online can follow you. Maybe you can give a brief introduction.
Yes. Oh, very loud. Yeah, my name is Jantine Rutging. I work at the Public Health Service and the Municipality of Amsterdam. And well, you've showed very clearly that heat is a risk factor for pregnant people and for infants and children. And there's many things we can do about heat. Very general things like greening the city or making housing cooler, making houses cooler. But do you also have any advice for interventions or policies that specifically protects kids or pregnant women from heat, or things that I can do or implement in my work?
Let's start with the pregnant women. Jeroen and Jasper, what should they do? How can they protect against problems?
Well,
Maybe
yes, sure. Go ahead, Jeroen.
No, go ahead, Jasper.
Well, you've been in this field for longer than I have. But yeah, it's tricky. So I think the most important thing for now is to make sure that pregnant women and children are actually seen as a high-risk group, which is also, you showed some data that this is often not the case. There's a nice study in the Lancet Child and Adolescent Medicine, I think from about 1 or 2 years ago, that showed that children are hardly ever incorporated in heat action plans across the world, including in the Netherlands. So I think the most important thing that we need to do in the short term is to make sure that they are seen as a vulnerable risk group. And then it's a great question, what are there specific advices that should be different or directed to them that are different for the general population? And I think that still needs further study.
Yeah. And then more for children and infants?
I think investing in original studies is really important, and advocating for increased physical fitness, because you see the differences in people. And most of these studies were done in military contexts or high-performance sport, but it's very clearly shown that in those populations you have increases in cardiovascular structure and function, so everything from vasodilatory mechanisms to increase blood volume, so you're able to deliver it better and more efficiently. Sweating becomes more efficient, and the content of that sweat changes, and this can all occur in children as well. So there's a lot of research, as I mentioned before. In the past, the problem is that the children now, these days, are more inactive and more obese than ever before. So we're not sure if all of that previous research translates to children these days.
So an important lesson that you think that should be done in children is to keep them fit, and that has a strong beneficial effect on how they can thermoregulate in the heat.
Absolutely, and true for pregnant women as well.
Okay. Then one more before I come to the next question.
He's got
Just to add that heat action plans have shown to reduce mortality. That has been shown in France, in Italy, in India, where since they've implemented specific warning systems, focusing on more vulnerable groups, which has been mainly elderly or for example in India living in slums where they live in very poor conditions, that they should focus on, and then they've seen a really reduction on the mortality rate. So including what Jasper says, including the pregnant women and children within the heat action plan is a very good step also from a political point of view.
Thank you, because we have someone in the room here, Jochem, who just published a paper on the effectiveness of the Dutch heat action plan. And if I understood correctly, we see that mortality is decreasing now in the heat, but it's very difficult to link that to the national heat plan because there's so many other factors. Can you comment on that? Am I correct in my conclusion?
Thanks. No, you're correct about that. So what we see is a decrease in risk over time when we look at high temperatures and mortality in the Netherlands. So that's before the first activation of the National Heat Plan and after the first activation of the National Heat Plan. But there are other things that changed over time as well. So air conditioning is more prevalent nowadays than it was 10, 20 years ago. In general, socioeconomic status of most people increased over time as well. So we don't know if it's really the heat plan itself or the other things that have led to these kind of risks.
Yeah. That makes it difficult, but so many literature out, and it makes it very likely that plays a role, awareness.
Yeah.
Coming back on the question of Jantine, there is one clear recommendation following from the research that Elina and Amber did, and that is dehydration effect. That's a real recommendation that comes up from your study, yeah?
Yeah, I think it's definitely important to be more aware of the need for adequate hydration in infants because they sweat. So that is indeed one, and just like advice for dressing infants as well. There's often this advice for babies to dress them in one extra layer than you would dress yourself. But then when it gets warmer, I think it's important that they do have the opportunity for that sweat evaporation to have more breathable clothing as well.
Yeah, there's a nice publication of Takako Fukuzawa in Japan. She published a study that in Japan people have the tendency to overdress babies also in the heat. So that's an important lesson also to learn. She has actually, and that's also another thing, she is one of the few in the world that has a thermal mannequin of a baby. So she can investigate the effect of heat strain, not only on humans, but on a thermal mannequin. But that thermal mannequin is not sweating. And when we confronted her with the data, she initially said, yeah, but babies don't sweat that much. So here I think we have an important point to advocate that they do sweat, and relative to the body size, it's rather similar, maybe even more than in adults. Does that answer your question, Jantine?
Yeah, thank you very much. And I think, or at least in Amsterdam or many other local heat plants, we're very willing to pay attention to pregnant people and kids and babies. And maybe it's also an open invitation that if there's more information on tips that people can do, then public health services are very interested in that. I was also, I've been searching online a lot for on guidelines from the Dutch Gynecology Association and verloskundige praktijken.
Midwifery.
Yeah. So, and there's almost nothing you can find online. So everyone has to come up with all the tips and tricks themselves.
Oh, yeah.
So maybe
I don't think
we can work on that together.
In general, I don't think it's a thing that is discussed a lot
No, I
in
don't
practice.
think so.
Which is partly why I try to put this topic also in the media, to make people aware.
Yeah.
I think there was a question also in the back.
Okay, yeah. First in the
Sorry,
back.
you're
And then
the,
back.
you're the
Yeah.
director.
No, perfect.
Ik kan wel lopen.
Yeah.
Because I've been doing the interviews with moms and just asking them what they do to stay cooler during the hotter days. One of the things that almost all of them say is that they really trust their midwife, so the community midwife. So really work together with them. But you also mentioned that because they don't have, the community midwives themselves don't have a protocol or any heat action plan yet, but they are willing to work together. But I think it's really nice for preventative health services to work together also with midwives within the community and to look at what can we do. And I think it's not necessarily only what can the individual do, but what can a neighborhood do? Is there maybe like a cooling center where moms can sit down, where there's an airco? Because in some neighborhoods where I did the interviews, those women live in social housing buildings and they cannot get those houses cooler. So is there maybe a cooling center in the neighborhood that they can sit down, or where there's extra water or things like that?
Thank you. From this, I learned that maybe we should contact the midwifery organization to see, to help them and see if they're interested to come up with guidelines, especially since you're telling them that they're highly trusted during the pregnancy, so they have an important role in advising. They were not in the target group in Go Hot, but after this discussion, I think that we should pay attention to them. Good idea.
Would be really great.
Yeah.
Hi, I didn't introduce myself before. I'm Lisbeth Hol from the Dutch National Institute for Public Health and the Environment, the RIVM, same institute as Jochem and Aisha. And I had a question because we support the regional public health services on environmental health issues, also climate change and health. And at the moment, we're producing guidance along with them for heat and childcare centres. And Elina, I think you're on our advisory board as well, aren't you? And one of the questions that's come up is what do we do about the outdoor beds that some of these childcare centres use? Is that a good thing? Is that not a good thing? And there doesn't seem to be that much evidence about the effects of that. But I saw your picture of the strollers and what a difference that can make, you know, in terms of materials, in terms of using fans. So I was wondering if any of you have got any advice on the use of outdoor beds for infants and very young children. Thank you.
Yeah, Shona?
Very interesting. I am not aware of any research specific to that right now. I am aware that in Arizona, for example, they were looking at homelessness and the types of tarps and tent that were being used in their areas, and there was a huge and marked difference depending on the materials. Also in Slovenia, they have daycares, and they usually have the resting things under trees, like olive trees or someplace well ventilated. And so the third thing to think about is the ventilation with fans, like you said. And again, there's a lot of new evidence being done by colleague Nicholas Ravanelli and others looking at fan cooling and how it's incredibly efficient. So we know that in order to cool, not every nation of every area can use air conditioning, and in fact, this is not good. And so they've run studies to look at what is the maximum temperatures that fans can be used safely or not cause any harm. And I know that those publications just came out recently. It's actually much higher than WHO standards, that you will not cause harm. But that's in the
indoors, isn't it? In the indoor environment.
No,
is that Ollie J? And
yeah,
I think I've seen some papers on that, but I thought that was using fans indoors, not outdoors. But
they were testing it in the heat chamber specifically, so they could calculate these heat balance equations really closely.
Elina, do you have anything to add because of your?
Yeah, no, I think it's a great consideration as well. So of course it really depends on their circumstances, whether the beds are open, what the temperature outside is. But I think in general, of course, just providing shade for the beds is very clear, and also just have more greenery in the environment, which makes a lot of difference for the beds that are outside. And I think it would be very interesting to also do a study specifically with these kind of beds and see different kind of situations and materials and how it influences the temperature inside.
Thank you. Jasper, you had a remark?
Yeah, so I tried to ask a different question earlier to Jeroen.
Yeah, please go ahead.
So
about the LGA.
Yeah, what is your hypothesis behind the link?
One of the hypotheses is it might go through gestational diabetes, and so one of the hypotheses that I'm not the expert, but one of the hypotheses that you might change your you might hydrate, you might drink more sugar beverage drinks, or consume other kind of unhealthy drinks that can increase your sugar consumption, and gestational diabetes is linked to larger babies. So that could be a potential hypothesis.
It would be interesting to study that, because it's quite intriguing that the impact goes both ways, right? So you actually get a flattening of the bell shape of birth weight, which is interesting.
Amber, is there any other question from the online audience? Yeah.
Well, first, someone want to add something here about the hydration part, because infants still recommend to only give breastfeeding before 6 months, according to the World Health Organization, and not to add water. So I think if we advocate for better hydration among infants, we should be very specific about this in our recommendations. And she added, I developed the WARM study in Belgium last summer, and we developed some recommendations for pregnant women and parents with infants to beat the heat. And I'm very happy to share those here.
Thank you. Yeah,
that's great.
It's Elina Holvoet.
Yeah.
I don't know.
Belgium.
Belgium. Maybe she added, I'm happy to share our recommendations. These advice were compiled based on guidelines from World World Health Organization, UNICEF, CDC, the Global Health Information Network, and Department Zorg of the Flemish government. It seems I cannot add the document here, but feel free to send me an email.
We'll do that. Thank you very much, Eline.
And then someone else is raising her hand. I don't know if we can give her the floor.
Yeah. I don't know if you can see it on the screen from the audience. Someone from the audience online raised a hand. And if possible, she can ask the question here. Yes. Hello, Stefan. Nice to see you. You have a question.
Thank you very much for this invitation. It's fantastic what you're doing. We always benefited so much from you. Thank you very much.
Thank you.
Yeah, I'm Stefan from Munich in Germany, and we work on a similar issue. And what I wanted to say is that we just, in the phase of publishing a book, a commercial company is publishing a book for midwives on climate change and health. And I had the pleasure to be part of our team writing the intervention. So what midwives should tell the women being pregnant. So Hein, you can make sure that they reach out to me and I can give whatever we already developed.
Great.
In exchange, we're having a political discussion now if we need specific regulations for child care centers against heat. So it's completely unregulated. So, in the office, you have a regulation until what temperature you're allowed to work and so on. So if you start that discussion on policy and regulations, I would be very happy to be involved and learn from your side. That's all from me here today from Munich. And I hope you will be able to share the presentations with us.
Yes, we'll do so. Of course, there were some confidential parts, so I will contact Jeroen and the others. But we'll certainly make a movie. We have excellent technicians here that work on that. And I look forward to contact you again about this topic. Thank you very much, Stefan. Then we're getting close to the end because we have something to drink here. Yeah. Another question?
Ja.
Oh, this is hard to understand. So I think
some background noise.
Some background noise. We are close to the end. I have one last question before we go to the drink, and that is to Shonda. I know you are comparing 70 countries in that global alliance, how fit they are and what they do in exercise. And Tim Takke contributes the data from the Netherlands. And so I'm so curious to know how our country is performing in that aspect, the Netherlands. I know that a lot of children take bicycles, but are we good or bad in exercise with our children? Can you tell a little bit more about that?
You put me on the spot. I think I think that you contributed for several of these global matrix.
Yeah.
There are 5 different rounds spanning 10 years. And so not every country is involved in every round. The first one involved only 15 countries. And I know that Netherlands were involved in the number 2 and number 3. But I don't know if you are involved in this most recent one. So the information is all freely available, and you can see it online. There's also several publications that are well cited that describe all of the different countries against each other and where are the positives and negatives. So I will dodge the question officially and invite everyone to have a look at that web portal where you can easily see each country involved. I do know that for the Netherlands, the active transport and your community and environment are very highly cited or highly graded, and that probably you would need improvements in things like physical education in schools, and there's other indicators which are generally very poorly scored globally. This is something like family and peers or that active play, but this is because there's just so little data that it's an area that needs to be researched more.
Thank you. Then with this answer, I think we conclude this meeting. I thank the audience present here, but also the online audience for the active participation. And especially, of course, I thank all the speakers for this meeting, and I want an applause for them. So again, thank you all. This concludes the meeting, and we will go to have a drink.
Bye, Jeroen. Thank you.
Bye, Jeroen.
Bye.